Welcome back to another explainer. All right, picture this. You're at the bedside, the patient is hypotensive, crashing fast, and the clock, it's absolutely ticking. It's that high-stakes, sweat-inducing scenario we all dread, but absolutely have to be ready for. You need answers, and you need them literally right now. So here's the million-dollar question. How do you quickly diagnose undifferentiated shock? I mean, when a patient is tanking, sending off conventional labs, or waiting around for a CT scan, yeah, that's just way too slow. You don't have the luxury of time to guess if you're dealing with cardiogenic, hypovolemic, obstructive, or distributive shock. Every single second matters here. Well, enter the RUSH exam. That stands for Rapid Ultrasound for Shock and Hypotension. First rolled out back in 2006, this protocol is a total game changer. It's built specifically to let you evaluate a patient's hemodynamic status right there at the bedside. Once you get the hang of it, it's the ultimate time saver. We're talking about narrowing down the exact etiology of the shock in, maybe 2 to 5 minutes? It's incredible. Okay, let's dive right into this step by step. First, we'll decode the RUS exam framework itself, and then hit the 5 key anatomical stations: the heart, the inferior vena cava, Morison's pouch, the aorta, and finally, the pulmonary system. Section 1. Decoding the RUS exam. All right, our ultimate goal when a patient is crashing is to get them from a dangerously low map to a healthy high map. And hey, that gives us our mnemonic. H is for heart, we're looking for effusion or failure. I is for IVC, evaluating fluid status. M is for Morison's pouch, essentially hunting for internal bleeding. A stands for aorta, screening for aneurysms. And P is pulmonary, checking for things like a pneumothorax. It's a great mental pegboard for when adrenaline is running high. Step 1. The heart. We're starting right at the center. The big question: is the heart the primary troublemaker causing the shock, or is it just desperately trying to compensate? Using your standard views, parasternal long and short axis, apical four-chamber, subxiphoid, you're looking for a few massive red flags. You want to eyeball the ejection fraction, check for a pericardial effusion that might be causing tamponade, and look for right ventricular strain. For RV strain, which screams pulmonary embolism, look for that visibly swollen right ventricle. Keep your eyes peeled for McConnell's sign. That's hypokinesis of the RV free wall, but with apical sparing, or the classic D sign, where all that built-up RV pressure shoves the septum into the left ventricle, literally making it look like a capital D. Let's focus on that left ventricular squeeze for just a second. Watch the ventricle through the cardiac cycle. If you're seeing a hyperdynamic squeeze, like the heart is pumping as if it just chugged 3 espressos but the tank is completely empty, that's a huge clue pointing toward distributive or hypovolemic shock. On the flip side, if that anterior leaflet of the mitral valve is barely moving and the contractile function looks completely shot, you're almost certainly looking at an exacerbation of systolic heart failure, classic cardiogenic shock. Now, if you take a moment to measure cardiac output, you get this absolutely brilliant integration matrix. Let's piece this puzzle together. Notice how distributive shock presents with both a high ejection fraction and a high cardiac output, but then look at cardiogenic shock: low ejection fraction, low cardiac output. Hypovolemic shock is tricky. You'll see a high ejection fraction because the heart is compensating, but the cardiac output is low simply because, well, the tank is empty. We'll hold off on that final IVC column for just a second. Step 2. Inferior Vena Cava. By evaluating the IVC, we're basically estimating central venous pressure, or right atrial pressure, to answer one simple question: is the pump failing, or are the pipes dry? This stark binary tells you so much. A small, highly collapsible IVC during inspiration, or a sniff test, suggests a low CVP. The tank is empty. That points you straight toward hypovolemic or distributive shock. But a dilated, plump, totally non-collapsible IVC, that suggests a high CVP. Fluid is backing up because of a blockage or a failing pump, which heavily hints at obstructive or cardiogenic causes. And this right here brilliantly illustrates how our new IVC data perfectly overlaps with the heart data we just grabbed. If you've got a hyperdynamic heart, a low cardiac output, and a very collapsible IVC, boom, you have a definitive profile for hypovolemic shock. It perfectly connects the dots. Step 3. Morison's pouch. So while the M technically stands for Morison's pouch, this step is effectively asking you to do a rapid eFAST scan. We're hunting for a hidden leak that's causing hemorrhagic shock. You're going to quickly scan the right upper quadrant for Morison's pouch and the liver tip, hit the left upper quadrant for the parasplenic space, and drop down to the pelvis for the rectovesical pouch in males or the pouch of Douglas in females. And don't forget to slide superiorly to check the thoracic cavity for a hemothorax. But how do we actually detect that hemothorax? Well, normally, Aerated lung tissue reflects ultrasound waves entirely, which creates a mirror image artifact of the liver or spleen above the diaphragm. You absolutely should not see the spine up there. But if you visualize the spine continuing above the diaphragm, that's your positive spine sign. It means those ultrasound waves are cutting through free fluid, like a chest full of blood, allowing you to see the bone hiding beneath it. It's a critical pathologic finding. Step 4. The aorta. Now we shift our focus over to the highly lethal vascular sources of hypotension. A ruptured abdominal aortic aneurysm will crash a patient unbelievably fast. The absolutely crucial number to remember here is 3 centimeters. A normal aorta, usually about 2 centimeters in diameter. An abdominal aortic aneurysm is defined as 3 centimeters or greater. And remember, you have to measure outer wall to get it right. If you have a hypotensive patient and you measure an aorta at 5 centimeters or more, you literally must assume it's a rupture until proven otherwise.
Now, aortic dissections also carry a massive mortality rate, but honestly, they can be pretty tricky to catch. A transthoracic echo is specific, sure, but it's not super sensitive here. You want to look for an intimal free flap just floating around in the aortic lumen, or signs of aortic regurgitation causing retrograde diastolic blood flow. If your gut, your clinical suspicion, is screaming dissection, but your bedside echo is completely negative, you might need to escalate to a TEE or a CT angiogram if the patient is actually stable enough to make the trip.
Step 5. The pulmonary system.
Finally, we wrap up the HI-MAP journey at the lungs to evaluate for a life-threatening tension pneumothorax. Let's systematically break down the logic here so we don't jump to dangerous conclusions. First rule, if lung sliding is present, a pneumothorax is definitively ruled out at that specific spot, so make sure you scan multiple points. Second rule, if lung sliding is absent, do not automatically assume it's a pneumothorax. And third, if you actually spot a lung point, boom, pneumothorax is ruled in with 100% accuracy. Let's check out the M-mode cues. Usually, normal lung sliding gives you the seashore sign. You get those straight lines above the pleural line and that sandy, static look below it. But an absence of lung sliding gives you the barcode or stratosphere sign, which is just straight horizontal lines all the way down the screen. But hey, remember rule number 2. An absent slide could also just mean severe consolidation, ARDS, fibrotic lung disease, or even a right mean stem intubation. So how do we actually prove it's a pneumo? We hunt for the ultimate diagnostic payoff, the lung point sign. This is the exact specific transition where you can visually see normal lung sliding intersect with the complete absence of sliding. It's the literal physical boundary where the collapsed lung meets the normal lung, touching the chest wall. Finding this doesn't just definitively rule in the pneumothorax, it also helps you quantify exactly how large it is. The heart, IVC, Morison's pouch, the aorta, and the pulmonary system. By systematically checking these boxes, you can drastically narrow down the cause of life-threatening undifferentiated shock in just a few minutes. So I'll leave you with this provocative thought. Armed with this HI-MAP framework and an ultrasound probe in your hand, is it finally time we officially retired the stethoscope in the trauma bay? Thanks for joining us for this explainer, and keep scanning.